Kiloh-Nevin Syndrome, otherwise known as anterior interosseous nerve syndrome, is an entrapment syndrome which affects the terminal motor branch of the median nerve. Branching from the median nerve in the proximal forearm, the anterior interosseous nerve passes between the two heads of the pronator teres muscle to run deep along the interosseous membrane. From proximal to distal, anterior interosseous nerve innervates the flexor pollicis longus, flexor digitorum profundus, and the pronator quadratus muscle. Manifestation of Kiloh-Nevin syndrome is mostly pain in the forearm that is accompanied by characteristic weakness of the index and thumb finger pincer movements. Etiology of Kiloh-Nevin syndrome can be grouped as either spontaneous or traumatic in nature. Among the most common causes of spontaneous factors are brachial plexus neuritis, compression neuropathy, and compartment syndrome. Traumatic causative factors include forearm fractures, such as supracondylar fractures, stab wounds, penetrating injuries, and complications of open reduction and internal fixation of fractures. The epidemiology of Kiloh-Nevin syndrome can be difficult to determine due to its rarity. Currently, it comprises less than 1% of all upper extremity nerve palsies. Kiloh-Nevin syndrome affects both men and women equally between the ages of 30 to 60 years of age and can present with bilateral symptoms that can at times be recurrent. The pathophysiology of Kiloh-Nevin syndrome is a result of a broad range of causes, such as inflammatory, compressive, and post-traumatic. It refers to not only a single pathological entity, but rather a common clinical manifestation of several different pathologies. Kiloh-Nevin syndrome is classified as a pure motor neuropathy and can be associated with additional signs and symptoms. Reports of additional findings can indicate underlying pathologies outside of the anterior interosseous nerve itself, such as median nerve or brachial plexus. It is important to have a comprehensive understanding of common variants of forearm innervation in conjunction with a thorough physical examination for associated features to provide important details when determining if pathologies reside within the anterior interosseous neuropathy or proximal to anterior interosseous nerve, such as pseudo-anterior interosseous neuropathies. Symptoms of Kiloh-Nevin syndrome can include neuralgic amyotrophic type pain in the upper arm or elbow that is preceded by weakness that also affects the flexor muscles of the forearm, diminished flexion of the distal interphalangeal joint of the index and thumb fingers, difficulties when gripping, pinching, writing, or picking up an object, normal sensory pattern distribution, potential wrist pain, and the inability for the patient to produce the OK sign. Differential diagnoses for Kiloh-Nevin syndrome can include stenosing tenosynovitis, flexor tendon adherence, flexor tendon rupture, and brachial plexus neuritis. It is important to differentiate Kiloh-Nevin syndrome from a high median nerve injury, as with a high median nerve injury, the patient would not be able to perform an OK sign. However, additional sensory symptoms could be present. Kiloh-Nevin syndrome can be confounded by Martin-Gruber anastomosis, which is present in up to 25% of the population. In these incidences, the anterior interosseous nerve gives off branches to the ulnar nerve, which create atypical motor innervation patterns within the forearm and hand. Hi Maddie, my name is Harry. I'll be your doctor today. After reviewing your history, I would like to conduct a complete neurological examination of the upper limbs. This will involve me moving your arms around, testing the sensation in your upper limbs. Are you okay with that? Wonderful. Prior to the examination occurring, can I just get you to confirm for me please your name and date of birth?
94/19/699.
Thank you. Now before we begin, are you in any pain or discomfort? No, perfect. So firstly, I'll observe both sides of your arms, looking for any muscle atrophy, any inflammation or involuntary movements. So can I get you to please hold both your arms out in front of you like this and close your eyes and just spread apart your fingers. Excellent. Now I'll get you to also turn your hands over with your palms facing upwards and keep your eyes closed. Excellent. You can open your eyes. So now I'm just going to test tone in your arms. So I'll just get you to relax your arms for me and just let me take you through the motions. So now all we'll be doing is performing some muscle tests, testing the strength of your muscles. So I'll get you to bring your arms up like this for me. Perfect. And stop me from pushing you down. Wonderful. Stop me from pushing you down. Stop me from pulling up. Stop me from pulling up. Bring your arms out in front of you like this. Slight bend in the wrist. There we go. And stop me from pulling towards myself. Yeah. Stop me from pulling towards myself. Stop me from pushing in. Stop me from pushing in. Bring your arms out in front of you like this. Wrist down. Stop me from pulling your wrist up. Stop me from pulling your wrist up. Bring your wrist up like this. Stop me from pulling your wrist down. Stop me from pulling your wrist down. Put your hands out in front of you, fingers together. Stop me from pushing your fingers down. Stop me from pushing your fingers down. Okay, now I'm going to do some muscle testing on your fingers. So bring your pinky finger out and stop me from pushing in. Perfect. And this hand, pinky finger out. Stop me from pushing in. Wonderful. And then bring your index finger out. Stop me from pushing in. Perfect. And this finger, stop me from pushing in. Now hands out in front of you with your thumbs facing upwards. Stop me from pulling your thumb down. Perfect. And this hand, stop me from pulling your thumb down. Perfect. Now I'm going to be performing reflex tests, okay? So I'll be testing the reflexes. Just give me your arm here and relax your arm completely for me, thank you. Perfect. Thank you. Go relax your arm. Wonderful. Perfect. This arm. Just relax for me, please. Perfect. I will test the sensation in your arms by using this piece of cotton wool. I will touch this on your chest as an example for you to know what it feels like. So you close your eyes for me, please. Did you feel that? Yeah? Okay, perfect. So I'll get you to keep your eyes closed. I'm just going to touch certain points along your arms, and you're just going to say yes when you feel the sensation, okay?
Yes. 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 Mm-hmm.
Perfect. Now I'm going to do the same thing this time, however I'm going to use a sharp sensation. So I'll get you to close your eyes again and I'll show you what this feels like. Did you feel that?
Yeah.
Perfect. So I'll just get you to keep your eyes closed again. And once again, I'm just going to touch certain spots in your arm. And you'll just say yes when you feel the sharp sensation, okay?
Yes. 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 Yeah. Yeah. Yes. Yes.
Wonderful. When testing the patient's flexor muscles, the patient's hand is supinated and relaxed. The first thing to observe is, does the patient have a normal finger cascade, which is when the patient's fingers are relaxed and they're all flexed at varying points. We can also provoke gross composite flexion by squeezing the forearm, and we should be able to see continuity of all the flexor muscles. To isolate the flexor digitorum profundus in the index finger, I would stabilize the patient at the middle phalanx of the index finger and ask the patient to bend down the tip of their finger whilst resisting against me. This would indicate flexion against resistance of the flexor digitorum profundus. Now we can test the flexor pollicis longus as well in the same scenario as the flexor digitorum profundus. However, we'll utilize the thumb and have the patient resist against flexion. So I'll get you to bend the tip of your thumb down and resist me against flexion. Perfect. The next test we'll be conducting is called the pinch grip test, also known as the OK sign, and it is used to test for compression of the terminal branch of the median nerve. So Maddie, what I'll get you to do is I'll get you to bring your tip of your index and thumb together like so. Perfect. This test determines if there's weakness of the flexor pollicis longus and flexor digitorum profundus to the index finger, and it is indicated by an inability for the patient to perform an OK sign, like so. Instead, the distal interphalangeal joint of the index and interphalangeal joint of the thumb would be hyperextended during the attempted pinch to pinch, like this. This completes the neurological examination of the upper limbs. If additional testing was required in the form of an electromyography test or a magnetic resonance imaging test, they can both be helpful in detecting and determining whether there is denervation, compression, and atrophy of any of the affected muscles. Thank you. The prognosis of Kiloh-Nevin syndrome depends on several factors. If the causative for compression of the anterior interosseous nerve is identified early, then the chances that the patient will benefit from the treatment increase. However, in some instances, surgery may be required. If the patient is suffering from neuralgic amyotrophic type symptoms, the prognosis is variable yet resolvable, although it can take between 2 to 3 years.